Today, we will explore the production, secretion, transport, and mechanism of vasopressin, also known as ADH or antidiuretic hormone. Furthermore, we will explore the effects of excess or insufficient levels of this hormone, as well as a study comparison of its use compared to dopamine in extremely low birth weight infants. Vasopressin, also known as antidiuretic hormone or ADH, is produced in the hypothalamus. Then, this hormone is carried to several regions of the brain, including the anterior pituitary, brainstem, and amygdala, by the parvocellular neurons. The parvocellular neurons are represented by the yellow neurons in the illustration, and the vasopressin are the small red molecules. The rest of the vasopressin is carried from the hypothalamus to the posterior pituitary by the magnocellular neurons represented in green. The posterior pituitary serves as a storage site for this vasopressin to be secreted into the circulatory system, represented by the blue, purple, and red capillary diagram in the illustration. Vesicles serve as the storage sites for vasopressin until their release is triggered by an action potential. Several stimuli cause vasopressin secretion, with the main trigger being dehydration. Dehydration causes plasma osmolality to increase, which signals vasopressin release. Other triggers include stressful situations, decrease in the volume of circulating blood, hypotension, and angiotensin II. As mentioned before, the main drive for vasopressin release is a change in osmolality. Osmoreceptors in the hypothalamus detect increases in plasma osmolality, which initiates vasopressin release. To a lesser extent, a drop in blood volume or blood pressure activates atrial volume receptors, which trigger vasopressin release as well. Vasopressin released from the posterior pituitary into the systemic circulation is carried to different vasopressin receptors at their site of action. The two most common sites include the kidneys and arterioles. In the kidneys, vasopressin exerts its action through V2 receptors utilizing cyclic AMP. In the vascular smooth muscle of the arterioles, vasopressin exerts its action through V1A receptors utilizing calcium signals. Utilizing the cyclic AMP mechanism of the V2 receptors located on the collecting ducts within the kidney, vasopressin increases the permeability of the collecting ducts to water. This causes a urine formation decrease, thereby increasing blood volume, water retention, cardiac output, and arterial pressure. Utilizing a calcium signaling mechanism through IP3 signaling on the V1 receptors located on vascular smooth muscle, vasopressin causes vasoconstriction. Also known as vascular resistance, this vasoconstriction increases the arterial pressure as well. Sometimes, the body produces hormones in excess by mistake. When antidiuretic hormone is produced in excess, it can be associated with several conditions, including leukemia, lymphoma, many cancers, Guillain-Barré syndrome, multiple sclerosis, epilepsy, porphyria, cystic fibrosis, emphysema, tuberculosis, HIV, and AIDS. However, the most common causes include dehydration, brain trauma, surgery, and most notably, syndrome of inappropriate ADH, known as SIADH. Those who suffer from SIADH may notice headaches, nausea, and vomiting. In more severe cases, coma and convulsions can also be experienced. With increased ADH, osmolality decreases in the plasma, with an increase in blood volume due to water reabsorption in the collecting ducts of the kidneys. Furthermore, the increased water reabsorption pulls water from the urine, making the volume decrease and the osmolality of urine increase. On the other hand, too little ADH causes low osmolality of the blood. One notable cause of ADH deficiency is known as diabetes insipidus. Those who suffer from this metabolic disorder may suffer from lack of ADH production in the hypothalamus or lack of ADH release from the posterior pituitary. In either case, low levels of ADH present in patients as polydipsia or excessive thirst and polyuria or excessive urination. In fact, Diabetes insipidus sufferers may experience chronic fatigue due to polyuria interrupting their sleep. Ultimately, untreated diabetes insipidus can lead to severe dehydration because of the fluid loss. Next, we will discuss a study called Vasopressin versus dopamine for treatment of hypotension in extremely low birth weight infants, a randomized, blinded pilot study. In this study, 3 groups of subjects were evaluated. The first group consisted of 10 extremely low birth weight infants that were hypotensive and treated with vasopressin. The second group also consisted of 10 extremely low birth weight infants that were hypotensive, but they were treated with dopamine. Finally, the comparison group consisted of 50 extremely low birth weight infants that had normotensive blood pressures and therefore did not require vasopressor support. For both experimental groups, infants were only included if they were born at less than or equal to 30 weeks gestation and less than or equal to 24 hours old when they received their first dose of either vasopressin or dopamine. For all 70 infants evaluated, the mean gestational age at birth was 25.6 plus or minus 1.4 weeks, and the mean birth weight was 705 plus or minus 154 grams. Any infants with chromosomal abnormalities, major congenital defects, hypovolemia, hydrops fetalis, or hypotension caused by lung overdistension, metabolic abnormalities, or air leaks were excluded to avoid confounding of data. As exemplified in this subject characteristic table, the only difference in ratings that were statistically significant between the experimental and control group were the APGAR scores and the initial blood pressure. This does not represent confounding for this study since these readings are directly related to the differences being studied. The mean blood pressure was lower in both experimental groups, but hypotension is the focus of this study. Furthermore, the APGAR scores were statistically significantly lower, but this score evaluates a newborn's well-being, so the infants with hypotension understandably scored lower than those with normotensive blood pressure. The main objective of this study was to evaluate the safety, efficacy, and side effect profile of vasopressin treatment for infant hypotension. The hypothesis the experimenters were seeking to prove was that vasopressin was safe for hypotension treatment of extremely low birth weight infants and at least as effective as dopamine. To evaluate this hypothesis, the primary outcomes included percent of infants that had an appropriate increase in blood pressure, as well as the time elapsed to reach the appropriate increase. This was monitored by measuring baseline blood pressure as well as every 20 minutes until blood pressure had been stable for 1 hour. After stabilization, blood pressure was continually monitored every hour for the next 4 days. Secondary outcomes for this study included heart rate, blood pressure, oxygen saturation, acid-base status, glucose, sodium and lactate levels, urine output, occurrence of necrotizing enterocolitis or intestinal perforation, respiratory values, ductus arteriosus occurrence, cranial abnormalities via ultrasound, retinopathy, and mortality. At 24 hours after birth, 90% of the infants in the vasopressin group and 80% of the infants in the dopamine group had achieved an appropriate increase in mean blood pressure. Furthermore, both groups exhibited no difference in the amount of time taken to reach an appropriate mean blood pressure. Therefore, both vasopressin and dopamine showed no statistically significant difference in either primary outcome of this study. The time to response in proportion to the response is shown in this graph. Of note, for the secondary outcomes, the dopamine group of infants did require more doses of surfactant than either the vasopressin or comparison groups. Also, the vasopressin groups had lower PaCO2 values and were not tachycardic during their administration period compared to the dopamine group. The most notable differences exhibited in this table are the ventilator days as well as the hospital stay length for these infants. While there was not a statistically significant difference between the vasopressin and dopamine groups, or the vasopressin and comparison groups, there was a statistically significant difference between the dopamine and comparison groups. This means that the vasopressin group had less ventilator days and hospital stay length, more like the comparison group than the dopamine group. It is possible with more participants, this could become statistically significant between the two experimental groups. While the small sample size of this study is of concern, vasopressin does appear to be a safe option for the treatment of extremely low birth weight infant hypotension. This study shows that both dopamine and vasopressin provide efficacy of treatment for this condition. Further evaluation with far more participants is necessary, but this study may be an indication that vasopressin could be a safer option than dopamine. The statistical significance between surfactant requirements, PaCO2 levels, and lack of tachycardia in the vasopressin group indicate it may have fewer side effects than dopamine. Also, while not statistically significant in this study, the treatment duration of vasopressin was 2.2 plus or minus 2.1 days compared to dopamine duration of 4.5 plus or minus 4.1 days. This would be a factor worth consideration in a larger study that might prove to be statistically significant. Obviously, a shorter treatment duration is desirable for these patients. In conclusion, vasopressin is of vital importance for regulation of osmolality and therefore water balance in the body. As we have discussed, both too much and too little of this hormone can pose problems for the body in this precise balance. Furthermore, in the study we evaluated, we learned that vasopressin's activity on blood pressure regulation can be quite beneficial in hypotension treatment. In fact, with more research, it may take the place of standard dopamine therapy with a better side effect profile.